Assalamu alaikum. Welcome everyone on board. Um, Actually, the topic for today, Bilal, is actually we will be just discussing about what anesthesia is. Not only for residents, for exam candidates, like because people think that anesthesia is anesthesia. So, in my uh, yeah, like my bet is that anesthesia has very little anesthesia, and anesthesia has everything actually, which is not to say anesthesia. Okay, so fortunately or unfortunately, we are in a specialty which is so vast that when we are, if we want to be a good anesthetist, we should have, like I say, that there is a care which is given by our father, and there is a care which is given by our mother. So the care given by the surgeons is actually like a father, and care given by a mother is like an anesthetist. Okay, so this is what we are. So we have to make our approach in a way that we are able to understand this specialty. And if we don't understand this specialty, unfortunately, we will not be able to, because when a new anesthetist, new resident come, or new anyone who is entering in the anesthesia, he is just thinking that anesthesia is intubation, okay, or anesthesia is spinal, or if you are like so these two things, people think that this is anesthesia, but unfortunately this is not anesthesia, because this is just a tip of iceberg, and we need to know, like when we are in the operation room, we have to know everything actually. Okay, so so I will just just highlight what we should focus, not only actually, because we should be in a constant learning, and every day we should be learning something, or we should be teaching something, because that's the only way we can progress. Because if we just sit and think that we know everything, unfortunately that day will be going down. So even if someone who is already established, just there should be an impulse and urge to keep on improving. Okay, so like there is a new concept, not new concept, but actually our name should be perioperative physician. Okay, because anesthesia is the only component by which we are making the patient sleep. But the other things which are parallel, they are more important. And if you like missing these things, actually you are not giving a proper care. Okay, like for example, if like if we I will go into details, but like if an anesthetist, even he does not know that during transfer of a specific age group or a specific patient, and some patients are more prone to develop something with reference to any joint dislocation or any fragility to their body. Even he is a very good anesthetist. He give a very good, wonderful, very difficult spinal, but when he's shifting, he does not care, or he lost his focus, and he may damage. Okay, he may give damage to the patient. So I'm just giving you one example. For example, you are an anesthetist. You have taken a very difficult IV line, but you don't know how to properly fix it. Okay, so you have passed the IV line, you have connected, and you have not properly fixed it, it will come out. Okay, so all your effort will go out. So actually, this is not anesthesia. Similarly, if you go more deep in, we should be knowing all the physiology, all the pharmacology, relevant anatomy, pathophysiology, medicine, monitoring, investigations. Anesthetist is also a hematologist. He has to interpret the labs. He is also acute physician, acute medicine. So That's how this specialty is. And if you, in this approach, now the word is for the people who are listening and who are thinking that what topic we are actually discussing. But actually, I the purpose of this discussion is to make your approach in a way that whether you are conducting a case or whether you are reading a topic, you should be knowing all the aspects. Because if you don't know all the aspects, unfortunately, you will not be able to handle the situation, or whether it is an exam or whether it is a um, like a practical conduct of an anesthesia. Okay, so like I use this word of perioperative medicine, our care starts when like patient is because there will be two category of patients. One will be emergency, in which you are just working in a certain place and you are being asked to conduct anesthesia of a patient which was not booked, suddenly coming in emergency scenario. And the other scenario will be elective. Okay, so not in our part of world, maybe like not frequently we have specific places, but actually there is a proper anesthesia clinic where the patients going for any elective surgery, they are going there. Okay, and there our approach is to, like we are working like a we are working like a physician. We are evaluating, like, no, we are taking history. Okay, we are doing some examination, we are doing some investigation. Then the surgery is one part of it. Okay, so surgery is one part of it, but actually we are investigating patient, we are doing so these are all components. And then according to the surgery, according to the history examination and investigation, we decide whether to proceed or we need some other disciplines to be involved. Okay, and this is a very important lesson or message I want to give. For example, we refer to proceed or refer, or some optimization, say. Okay, so optimization will be, of course, you will not be the primary physician to optimize something, you will actually refer. Okay, so in the referral, which the biggest problem which we face, that and this starts from the very first day of your anesthesia and training, and actually it goes on because we refer the patient cardiology clearance. Okay, and we don't know what actually we want from the cardiologist. We write endocrine clearance or whatever, but we actually even for example, if there is a cardiology, so you should be knowing what you want exactly, what is your aim, what actually you are fearing from, what is your, like for example, if anything will not change the management, you are doing only for risk stratification. Okay, or you want the cardiologist to do some investigation so that you know that, for example, I'll give you one example. A patient is coming for a cancer surgery. Okay, and you saw this patient and you came to know that this patient has received chemotherapy. Okay, so this patient, if he this patient has not been investigated for the decrease in cardiac function, actually your aim is to get clearance with reference to any cardiac decompensation following chemotherapy. Okay, so when you are referring the patient for cardiologist, you should know what you want from the cardiologist. So you will be referring that this, you have to give the relevant point, that this patient is receiving has received chemotherapy, and now this patient is going for a surgical procedure. So you should be knowing, of course you will filter this patient on the basis of this history examination and some of the investigation, but actually you have to make sure that when you are referring a patient, you should know what you want from that specialty. Okay, otherwise your referral is incomplete, or you can say your referral is useless, because you don't know what you want from the certain and what will change. Okay, what management will change, like for example, now this patient underwent chemotherapy and for the cancer, and now this patient is coming for surgical resection. Okay, so actually this will just tell you that initial cardiac function was like that, and now the cardiac function has been deteriorated. So your question will only, because this is a cancer surgery, you cannot delay it forever, and you cannot delay it. because if you will delay it, the whole purpose of giving this chemotherapy or any that will be, because if you delay for only for cardiac evaluation for 3 weeks, you are doing a disaster. Okay, so this is your decision making, not only decision making, but actually this is your approach, that what you should do. You will only see, your purpose will be that if any management or any thing which will be in reducing the or optimizing the patient situation. So your purpose will be that any irreversible component or any reversible component in this patient, so your focus will be only on that component. That the cardiology will not only assess, they will give their opinion, and in anything which can be done immediately. Okay, so this is the approach. I'm just giving you one example. So when you are evaluating a patient, your approach, of course, at this moment, I will not be teaching you each and every aspect, but this should be your approach. Like coming back to from the part from where I started, that we are evaluating a patient going for a surgery. So we have to evaluate what is the relevant history, what is the situation of the patient. Now this patient is going for a surgery. Does this patient, according to the history and examination and whatever investigation you have done, does this patient need any optimization? Does this patient need another thing also coming from this? Like for example, you are again the example of this cancer. You had a patient, you saw the CT scan report, and there is pulmonary nodules. Okay, pulmonary nodules, and now you need pulmonary evaluation or pulmonary clearance or opinion from the thoracic surgeon, thoracic surgery. Actually, your purpose is only their documentation, that whether this lesion is creating any problem, whether this lesion is creating any effect on the pulmonary functions. If yes, a lot of things you will also assess, actually. Okay, but like when we are working in as a team, we need sometimes a lot of actually a lot of times these evaluations, referrals are for actually medical legal purpose. Okay, like you are, because you are an anesthetist, you are seeing something, you need their stamp. Okay, their opinion regarding that thing. So according to the severity of the condition, of course you will filter that. For example, if the patient, you can guess that there is no interval change in the symptomatology of the patient. The patient is fine, the patient does not have cough, does patient does not have any hemoptysis or any decrease in gaseous exchange or any mechanical respiratory functions. You can, yes, yeah, you can have an assessment, and then you will be getting their opinion and any optimization which will be. So this is the purpose of referral. So next time if you are referring any patient for cardiology or endocrinology, you should be clearly knowing what you want. Either will be optimization or risk stratification. So these two things you should be very clear. Okay, because if it is high risk for something, you will outweigh risk versus benefit for the surgery versus optimization for that case. Okay, and some things will not change. Like for example, if any procedure, by the way, another important point which you should be thinking, that actually emergency is divided into one real emergency, which actually in some setups we say E1, and some surgery which are E2, and actually these are labeled as urgent. Okay, similarly, one elective surgery, there are two sort of elective surgeries. One is actually purely elective, and one is actually planned surgeries. The example of planned surgery will be, say, for example, this cholecystectomy, laparoscopic cholecystectomy. Okay, because now even has been changed, because now actually they are doing it as an urgent. Usually now they are doing because there was in a previous concept that don't do cholecystectomy in acute cholecystitis, but actually now there is growing trend that they are doing it in acute phase. So that has even changed something. So like this laparoscopic cholecystectomy is never elective, because you cannot leave the stones to waiting for the stones to hang around and have a walk towards the biliary tree, blocking it, and the patient develop this jaundice. Okay, so you have to you have to identify which cases are absolutely elective. So actually, cosmetic surgery, plastic surgeries, these things which are purely elective or only. Otherwise, majority of cases actually they are planned surgeries. They are not actually purely elective. Like if you say, for example, TURP, I'm just giving you a thought. TURP, the urethral resection of prostate. Actually not a purely it's not purely elective procedure, because if it is too big, it can cause obstruction at any point of time. So you have to do it. Yes, symptoms will be relieved. If the other conditions need some optimization, so you can plan a surgery. You can have some optimization. You can have risk stratification. You have opinion from the cardiologist or pulmonologist or whatever is required for that old man who's coming for the procedure. But you cannot delay it forever. And even this is small thing, that when you are evaluating a patient for TURP, one thing you have to see whether it is only like enlarged prostate, or just to add on, if the PSA levels are high. So the discussion with the surgeon will be, are you suspecting a cancer? Are you suspecting something more than only prostate enlargement? So that's why discussion with the surgeon is very important. Okay. So the purpose of these words is, whenever you are evaluating any patient, your purpose is to identify the patient on the basis of the relevant history, examination, and the investigations or whatever you want. And then discussion with the surgeon is very important, because discussion with the surgeon, what they want, what is their goal, because every surgery has different horizon, why they are doing that's why do they are doing that surgery. Okay, so and then you will decide what to do. So this is just few words about pre-operative evaluation. So the next step will be that how will you proceed with the surgery, and you will, so now there will be another decision which actually you have to take. But of course there are multiple they say that whether this case is to be done as a day surgery, or it is an elective procedure, or elective inpatient, or you need the patient to have HDU or ICU. Okay, so this is another, because patient is elective, for example, but still you have to decide whether the patient can be done as a day case. You can send the patient home after the surgery, because this is a growing trend. And now I will, at this point of time, I will introduce a lot of people know about it, the concept of ERAS, enhanced recovery after surgery. Okay, so because now, even if nobody is asking you to have ERAS, but actually this thing should be in your mind when you are evaluating a patient, or you are when you are planning a surgery, when you are planning anesthesia care for any patient. So concept of ERAS should be there with you whenever you are handling any patient. Okay, or if you are managing plan for ERAS, so day surgery and ERAS is side by side. And actually, another thing, I tell you something, that a number of countries where the lot of things are through the insurance company, there is a peer pressure from the insurance company with reference to actually this thing. So it has become totally non-technical, but actually day surgery will reduce the hospital burden. It will reduce the hospital stay. So one component, they only sell the component, oh, this is good for the patient, but actually this is also because of this thing. But of course, this is non-technical thing, but this thing should be in your mind, that if you are working in a private hospital and you are an unnecessarily inviting the patient for in admission, actually this is not good. So you should be able to identify which patient is not suitable for day case, or which patient is can be done as a day case. So this is a very important decision. So as an anesthetist, you should be knowing which patient needs admission, which patient does not need admission, regardless of this pressure. Okay, of course you have to keep this in your mind. So this is a very important point. And then you have to identify which patient will be needing extra care. Okay. Any patient which can decompensate post-operatively, you will be making sure either HDU or ICU is there. HDU is relatively like one organ system other than ventilation, or if there is more than or one organ system involved, then the patient will be ICU. Of course, this is a detailed discussion, so I'm just giving you a taste. Okay. This will be planning. Then a number of things that when you are putting the list, you have to decide certain cases which should be done as a priority. Okay. So you make the list accordingly, that you have to do certain cases earlier in the day, and certain cases you can do later on in the day. So this is like a lot of things which will be logistics. Okay. Logistics. I will be coming to the preoperative optimize sorry handling of the patient with reference to anxiolysis or preemptive analgesia or something else, but logistics. Okay. So logistics will also be decided when you are evaluating the patient. Like for example, you are evaluating a patient who is very obese, like he has a class 3 obesity with BMI more than 50, for example. Okay. So now if you don't understand this thing, that you have to inform or you have to plan accordingly. You need a special table, you need special monitoring of equipment, you need everything different from others. So if you don't understand this thing when you are preparing, you will be in trouble. So logistics is with reference to the patient category. So special things you need, you have to prepare not only the OR staff, with reference to the other paramedical staff and your anesthesia technician or your anesthesia assistant. So you have to prepare the logistics. So in logistics, a lot of other things are coming. So for example, if you know that there is a patient with some infectious disease. Okay. Infectious disease. So now you need to know, need to inform all the staff. They have to, of course, universal precautions are being done for every patient. But if you know already that this patient is hepatitis B or hepatitis C or HIV or anything which can be community, TB, tuberculosis or anything, you have to identify, and you should be knowing as an, of course, the story from where I started. Anesthesia has everything other than anesthesia. So we whatever we are discussing actually is not the spinal or intubation. It has everything which we are discussing right now is totally different. Okay. So this is another thing you need to identify and plan accordingly. And similarly, if you need any special monitoring, any special equipment in the OR, you have this also comes in the logistic. Like if you need any surgery in which you need rapid infuser system, you need cell saver, okay, rapid infuser system, or you need fluid warmer, or you need anything extra than a normal routine one. So it also comes in logistics. Okay. That in this patient, you need other than the normal standard 1 and standard 2 monitoring, you need cardiac output monitoring, or you need invasive monitoring, or you need fluid warmer, or you need level 1 infuser, you need cell saver, you need any special monitoring like neuro monitoring. Okay. You need BIS, you need like anything. So this is the time when you will be preparing the OR for that thing. You will be telling that you need neurophysiology, neuro monitoring for this patient, for example. So you will make sure that these things are available when you are giving the anesthesia. So this is this is an example. Now you can think about it, and every case you will find few points about it. Okay. This is another thing we should be preparing. Then, of course, for example, if we just think about preoperative anxiolysis, so anxiolysis will be a number of times before one night before you can advise some benzodiazepines or anything to make patient anxiolysis. So anxiolysis is one of the component. Then acid prophylaxis. Okay. You will be doing something for acid prophylaxis. Then you will be doing something as preemptive analgesia. Okay. Preemptive analgesia. So preemptive analgesia means you are giving some medications which will not only. Okay. Okay, thank you, Bilal. um, Okay. Anyway, so preemptive analgesia, like you are advising, for example, you are advising gabapentin. Okay. Gabapentin has opioid sparing effect. You are giving paracetamol. Okay. You are giving NSAIDs before. Okay. Even for example, if you have a fracture coming as a, so you are planning to, before transfer you are planning to give for instance you are giving a block, femoral nerve block or sci-fi block, any block to relieve the pain of the patient while transfer. So this is also sort of part of your management. Okay. So then another thing will be the like optimization, or sorry, handling of the preoperative medications. Like for example, if the patient is hypertensive or diabetic, or a patient has Parkinson's disease, or patient has any medication which patient need to take or need to omit, for example. So you will be or increasing or decreasing the requirement. So all of these things will be in your domain. You have to make sure you are advising proper NPO. You are advising proper care with reference. So this will be also the preoperative preparation of the patient. Okay. So these things you should be knowing well before you are proceeding for anesthesia. Okay. So then after that, few important things we need to prepare. One of them will be airway management. Okay. So airway management, some people will be saying, yes, we are giving local anesthesia, or we are giving only block. So still we should be thinking about airway management. Yes, wherever the word anesthesia come, you have to be ready for any havoc. Like if, for example, if you have a patient with difficult airway and you are giving even local anesthesia, you should be ready for intubation, because patient will not tell you one day before that, doctor, tomorrow I will have, or I will not develop local anesthesia toxicity, or I will develop local anesthesia toxicity. Any patient can develop local anesthesia toxicity. Okay. Because people, there is a concept with this reference, I will just highlight one thing, that people say that 2 milligram per kg or 2.5 milligram per kg is for bupivacaine and lidocaine. But do you think, if you, even if you give 1 milligram per kg, this is safe dose, but by mistake if it goes into circulation, patient can develop blast. Okay. Because actually it is the toxic levels transiently in the blood, not the absolute dose, which is the troublemaker. Okay. So at some time, maybe you have used even relatively more dose, but it is in a place where the absorption of the drug is, chances are less. Maybe you are giving even more than this safe dose. Usually we are not giving it. Okay. But I'm just telling you that at places where are more chances of toxicity, you will be taking more care. Okay. Similarly, you might have this what do you say, that like inadvertently other complication occur which you were not expecting. So even with local anesthesia or blocks, you have to be prepared for airway management. And airway management, not only intubation, you should be thinking about giving the oxygen therapy, whether through the nasal cannula, face mask. You have to make some positioning changes, like you have to make a ramp position, or a little bit of head up position, even during local anesthesia. So you have to make sure that your plan is ready for it. Okay. So airway management is the very important component. Of course, there will be supraglottic airway devices, nasopharyngeal or oropharyngeal airway, or it goes up to the invasive management of the airway, even like endotracheal intubation, video laryngoscopes. And if you have any doubt, you will be keeping, this is also part of airway management, that you have to keep ENT or any surgical specialty which can do the tracheostomy, or you yourself has the capability to do percutaneous cricothyrotomy or percutaneous tracheostomy if needed. So this is all part of airway management, starting from simple nasal cannula or face mask, or simple things to the maximum ones. Okay. Then another important component which we should be focusing is the patient positioning. Okay. And actually the things which we are discussing is relevant to any case, any surgery, any anesthesia care, any topic. These things are related. So I'm just trying to give you a brief overlook what you should be thinking. We will just try to finish in next 15 to 20 minutes. We will finish. So patient positioning. So you should be knowing what are the limitation. Like for example, you are patient coming for at URP. Okay, you give a spinal, and you, as an anesthetist, you did not evaluate that this old man is having limitation to the joint movement, and if you will try to cross that limit, unfortunately, you can dislocate the limb. So you will be surprised that in not only the conduct of this conduct of spinal anesthesia, if you don't know that your patient has physical limitation and you cannot make the lithotomy position properly, this is also your responsibility. I know that you will be say, no, this is surgeon and this and that, but actually this is your responsibility. Before giving any anesthesia, you should ask the surgeon which position you are going to take, and then you have to make sure that is there is no limitation in making that position. Okay, so I hope you understand, whether it is lateral position, whether it is lithotomy position, whether it is prone position, whatever. Like for example, I give you an example. You are yes, ram for bariatric. So you are having a patient coming with a very simple pilonidal sinus. Okay, and the surgeon wants prone position. Okay, and you forgot to ask that this gentleman has recently retinal surgery. Okay, and you don't care, and unfortunately, you will damage. I hope you understand. So this is very important. Patient positioning is very, very, very important. Patient positioning is like sometime we will be thinking, oh, this is very simple thing, but no, it's something very, very important. Okay. So make sure whenever you are dealing with any case, any surgery, you should be knowing the problem. I'm giving you one example. I'm giving you just a taste of everything. Okay, so patient positioning is very important. Then of course there are more detailed discussion we can do with reference to joint dislocation, nerve injury, any specific problems which you will be facing. You have made a prone position and you did not take care of the genitalia, you did not take care of breast tissue, you did not take care of abdomen, and so it will be problem. So the message is that patient positioning. Okay, then some of the common things which you will be doing. Of course, I'm not touching the anesthesia. Anesthesia is there. You have to decide which induction agent you have to use, which induction agent you should not use, what will be the plan for analgesia, multimodal analgesia, paracetamol, NSAID, ketamine, regional blocks, local infiltration. That's a separate. Okay, but other than that, maybe you will not be thinking about the fluid therapy. Okay, fluid therapy is not putting only so-called normal saline. Okay, actually this is another thing that actually should we say it normal saline? Unfortunately, no, because its name should be abnormal saline. Because actually there is no compelling indication to use this solution. So sodium it has is 150, chloride it has is 150. It is much more than the normal range of sodium, or 109 of chloride. So it's not a good solution. So I'm just giving you one example. There is a myth, oh, patient is diabetic, so how can we use ringer lactate? This is wrong perception. There is no problem in giving ringer lactate in a diabetic patient unless he is not in acidos this DKA, or not in uncontrolled thing. You can give ringer lactate. There is no problem, because you are giving you are giving insulin, or there is a like system which is going on for the control of blood sugar. And if the patient liver is fine, he will metabolize he will handle the lactate. What's the problem, my dear? There is no problem at all. Okay, so there are so many myths previously there was a terrible solution which they use in pediatric patient, this 10% dextrose when 0.18 person a normal saline. So actually, this was a killer solution, which was called as PEDS solution. I'm so surprised that it's available in some parts of world still. So it's a terrible killer solution. Okay. So there are certain other solutions you should be knowing, whether you are using colloids, whether you are using crystalloids, you are using dextrose containing solutions, you are whatever. So you should have a clear plan, which solution and how much. Another thing, another big myth which we all have. Oh, patient will go in overload. Please don't good no don't give more food. Patient does not have Foley's. Oh, don't give more fluid. Patient will go in overload. So I'm working in anesthesia since 20 years. I have never seen a normal patient going in overload. Okay. So what happens if you do more water? You go to the bathroom. So there is no problem. So what's issue? And even for example, if you have a surgery in which you have not put the Foley's, still this is not a reason that, for example, if you want the patient, there are risk factors. I give you one example. If the patient has history of PONV, post-operative nausea, vomiting, okay, and you are denying the patient with the fluid because only because of Foley's, or you are risking that the patient will have bladder distension and it will become distance, but you are denying the patient and you are keeping the patient more prone to PONV, because how you feel in the morning if you have not taken the breakfast, you are feeling a little bit of nauseated feeling. Okay, if you are have not taken something for a while, actually you yourself feel nauseated. So actually, the patient is also a normal human being. You are keeping the patient NPO for say 8 to 10 hours, and now this patient will be prone. So please make sure, don't be afraid of giving fluid. Nothing will happen if you are giving fluids carefully. If the patient does not have any problem with the liver or heart or kidneys, don't be afraid. And Foley's you can just have an in and out after the end of the procedure. You can have in and out if you have feared this thing. This is one thing before extubating the patient. This is one thing. Or don't hesitate to ask the surgeon to have Foley's. Why you are afraid? Yes, some say there will be some problems with it, but actually just placing Foley's and removing it, it's not at all a problem. So make sure you are not giving less fluid. So roughly, because whenever you are giving fluid, you have to take care of the deficit, you have to take care of the maintenance, you have to take care of the third space, you have to take care of the this insensible loss, then any drains, even urine is coming out. So all things you have to replace. So unfortunately, I have seen 99% people give less fluid than the required. So this is a big problem. And not only PONV, if you are not giving good amount of fluid, this is a risk factor for surgical site infection. Okay, this is a risk factor for a number of problems. So why you are denying your patient? Yes, you can have a debate that use the science of POCUS, okay, and use the science of judicious fluid therapy, goal directed fluid therapy. This is something else, but at least you make sure you are not giving less amount of fluid. Okay, so up like just to recap: preoperative evaluation, optimization, referrals. Then we did the logistics. When then we did the how to how to
Um,
prepare the patient, how to prepare the patient for any specific surgery or anything. And then like we discussed about some of the other things which actually a number of time we miss. Then we discuss about positioning, careful taking care of the normal limitation of the joint, taking care of the pressure source, pressure points. Even you have attached a three-way with the IV cannula, and you did not see that that is very pressing any place. Okay, pressing any place, and then after the patient wake up, there is a big compression over there. Similarly, you have not fixed the cannula nicely, and it came out. There are even incidents of like extravasation of fluid because of improper fixation. I myself have have faced 1 year ago a day case. The baby received around 400 to 300 ml of fluid in extra position with the whole limb swelling. Okay, so this happens. I'm really then another thing. One thing I forgot is the prevention of never events in anesthesia. Never events. Okay, never events is actually this WHO surgical safety checklist. Correct site, correct patient, correct procedure, correct location. So all thing. Then, with reference to medications, correct labeling, correct concentration, correct site, because these are no anesthetist can say that I have not done a never event in the career. If he's saying I'm absolutely virgin in doing any mistake, he is lying to you. I don't believe this thing that any anesthetist has not done any mistake in his career. But make sure you avoid never events. Never events, actually, I have discussed in detail. So you can find in the YouTube channel. I have discussed it. I can share it to anyone who wants. So actually, up till now, whatever we have discussed, that remember one thing, there are certain things which are actually not part of anesthesia, but you have to take care about it. Then coming to the last few points, one of them actually monitoring of the patient. Okay, so monitoring is not only looking at the numbers. You have to look at the trend. You have to look at the situation. Like, you will be asked to, for example, you have given the task to do hypotensive anesthesia and fixed at 60, for example, 60 of mean. Now this patient had renal impairment. Okay, and this patient had, you have given NSAIDs as well. The patient was diabetic as well. Okay, and now there is a blood loss. Okay, and you are afraid of giving more fluid, so you did not give much of fluid. So now, and you are keeping hypotensive anesthesia for a long time, this patient will definitely is at risk of going in AKI. Okay, acute kidney injury, because the renal perfusion pressures for is not 60, it's 80. It's 80 to 180. Okay, so you have to make sure you are taking care of these things. You can deny the surgeon that yes, I we cannot bring the hypotensive anesthesia to that extent. You can have some other strategies to reduce the bleeding, like elevation, use of tranexamic acid, use of tourniquet, according to the scenario. There, in certain condition, you can use tourniquet, you can use some local vasoconstrictors. There are so many things which you can do, but in this is your responsibility to tell that this patient is not safe to have. And then very important point with reference to this specific hypotensive anesthesia point is that sometimes you are just putting a BP cuff. Normally, maybe 5-10 millimeter mercury, you don't care. But in this patient, it's very important. Okay, because if the proper size of BP cuff is not there, and you whatever reading you are is not reliable, what will you do? You have put the BP cuff in the in the lower limb, and the size was not appropriate, and you are trying to follow it. So preferably, if you have a prolonged surgery, you should not do hypotensive anesthesia without arterial line. Okay, you have to monitor the base bed to bed monitoring. And then what you can do, if for example, with reference to shoulder surgery, if you are giving hypotensive anesthesia, because this will be sitting beach chair, this sitting position, so you zero the transducer at the level of tragus, not at the level of heart. Okay, because it will indirectly reflect the cerebral perfusion pressures. So this will be a good idea to maintain the perfusion pressure with reference to triggers rather than with the level of heart. So then another with the same thing, you had given hypotensive anesthesia. Sometimes some surgeons are good. Some surgeons will tell. Even only yesterday I was doing breast surgery, and they were having like low blood pressure. They were asking, and at the end of the surgery, I asked my resident to increase the blood pressure. Why? The surgeon did not ask, they forgot actually. I increase the blood pressure because when they are closing, if you did not maintain the blood pressure to the normal side, maybe some oozing, some bleeding, they will miss. Okay, so this is part of your anesthesia care. Actually, this they are doing the surgery, it's their responsibility, but we are working as a team. So you should be thinking the steps of surgery, at what time you need to do something. Okay. Similarly, the same thing which just clicked my mind is that the with reference to tourniquet. When they are placing the tourniquet, when they are releasing the tourniquet, you have to be taking care, and you have to, even sometimes you have to take care of the end-tidal CO2. You have to take care, the patient can have hypotension. Reversing with the position, creating a position and reversing the position will have. So monitoring is not only looking at the numbers. Okay. Monitoring is anticipation, like you have to change the position. You are giving nitrous oxide, or you are giving 50% oxygen, and now you have to turn the patient, in which you need to disconnect the ventilation for some time. Actually, you should convert it to 100% oxygen before doing it. I hope you understand. I will repeat that if you are standing in the operation theater without thinking, unfortunately, you will do some mistake. So if you know that you will be disconnecting the connection, the circuit, you have to make sure you give 100% oxygen for few minutes, so that you increase the apnea time and you disconnect the ventilation. So anticipation is very important. You are doing a orthopedic case and there is a bone cement and you are sleeping, you don't know that there can be bone cement syndrome, and already the patient was having blood pressure around 90/60, and you were happy with that blood pressure. But if the the problem occurred at that time, unfortunately, patient will lose, you will lose, you will be in trouble. Okay. So certain steps of surgery, you have to make sure that you are ready for it. You are starting a blood transfusion. Okay. Or you are giving any antibiotic, or you are giving any something, you don't have, you are giving a block, you don't have the intralipid. Okay. You are giving blood and you don't have antihistamine or epinephrine. So whenever you are giving blood transfusion, make sure, yeah, that you have epinephrine, you have antihistamine. Okay. You have steroids with you, and also actually even bronchodilators, you can say. So if you of course it can occur in any patient, but specifically if you are doing intentionally, you are doing something which can create a problem, you should have this anticipation. Okay. So similarly, there are so many things you can think one by one, and every surgery you are doing, any case in which there can be vagal stimulation, and you should be ready. Maybe if the initial heart rate is low, of course people will say that there is no indication of prophylactic atropine, but actually practically I'm telling you that if you the heart rate was as low to start with, it's better you can use glycopyrrolate, because it will not make the heart rate crazy, and actually it will give you some window. Okay. Like for example, if you are doing ophthalmological surgery, or if you are doing cervical surgery, or anything in which they can have bradycardia, it's better to keep the heart rate around 80 rather than 60. Okay. So because if the heart rate is, of course you have to look at the overall situation of the patient, but it is wise, it is better to use a little touch of glycopyrrolate or any medication. Like you can use even ephedrine if the blood pressure is also low. But I'm just giving you an idea. That's how you will be picking it up what you need to do. But actually you have to anticipate the possible complications. Like they are doing putting the trocar, and you are sleeping, and you don't know that patient, even the depth of anesthesia which is there to start with, you are very happy, you did the intubation and everything, and now they have to put the trocar, but you forgot this concept that maybe the patient has MAC. But when they are giving the NCN, or they are doing something more painful, you don't need MAC, you need MAC bar. Okay. Blunt adrenergic response. The MAC bar is around 2 to 3, if I'm not wrong. Okay. So MAC bar value is 2 to 3 MAC. So this is one of the things that you have to anticipate. You will not wait for things to happen. You will anticipate and act accordingly. And the same will be for anything: tachycardia, bradycardia, hypoxia, hypercarbia, acidosis, analgesia, muscle relaxation, and all other things. Okay. So, and at the end of the surgery, you will make sure the extubating conditions are there. And then maybe you planned a patient for day case, but now you intraoperatively something happened and now you are not happy. You will make sure the patient is going to the appropriate place. Whether you did not book the patient for ICU, but any unexpected, you will not only send the patient to the ward only because you had decided not to send the patient to ICU. No, you don't have to become a hero. You have to decide, you have to be flexible. Okay. And then you have to decide whether it is safe. So then the concept of post anesthesia discharge criteria or post anesthesia problems. So actually, because now we have already taken a lot of time, the purpose of this discussion was that that like you should be anticipating, because anesthesia is for anticipation actually. Anesthetist is and in endotracheal intubation there are so many ways, and I would if Bilal is still there, I would request him for, because he's expert of airway. So actually intubation can be done by the highest ranked anesthetist, or intubation may be done by is even a non anesthetist. Okay. So anesthesia is not only intubation. Anesthesia has so many things other than intubation. Okay. So the purpose of my discussion was to just like have a brain exercise of what good anesthesia care is. Okay. So anyone wants to ask any question before I will request Bilal to have some words from New York. Anyone wants to ask any question, please? Okay, Bilal, if you are free, you can have few words. I think Bilal is not. Anyone wants to comment anything before I finish? So actually, the thing is that uh, I will highly recommend you that when all of you, whether you are doing post graduation or you have already passed your exam, please a humble request to you, don't do the training for the just for the sake of passing the exam. Okay, I know that usually we our focus is only okay in only passing the exam, but the thing is that if you don't have the concept, if you even if you pass the exam, it's useless. Okay, you should have good, and this thing I always ask to all of my colleagues. Now right now 12 people are there. Would you like to give anesthesia to your mother? Would you like your mother or father or your dearest one to be anesthetized by a person who only did whatever he did for only passing the exam? No, you would like to go the best in the town. But so why you are so hypocrite that you want something best for your family and you are not giving the best to someone's mother and someone's father? So please have mercy. We are whatever religion we are, whatever place we are. Remember one thing. Uh, Most important thing is that you know the concept. You should know what you are doing, because if you don't know, unfortunately, you will do harm. Maybe 9 cases nothing will happen, but in 10th case you will be in trouble. Okay. What is the least of finally MBBS must? Uh, Osama, actually, there is no limit to least what a final year MBBS student should know. Actually, I think this is a little off topic, just, but I will uh, uh, give you a few words. Actually, you should be, if the most important thing which should be know is that what you need to do after final year. That's the most important thing, because unfortunately, if you enter in residence in internship or house job without any clue what you want to have to do, unfortunately, this is the biggest misinformation you have. So this is a time that I can highlight the importance, and actually this is relevant to anesthesia or even any other specialty. Integrated medicine. Okay. Okay, so integrated medicine actually is like, for example, integrated medicine is that you, whatever, like for instance, you are focusing on CVS, you are anesthetist, you are reading CVS, but Actually, if you don't know the physiology of cardiac cell, okay, just tell me how can you understand a disease? If you don't know how the conducting system of heart occurs, how can you understand arrhythmias? If you don't know the basic physiology, the basic pharmacology, the basic pathology, you cannot understand the medicine. So these are integrated. So if you ask me, Osama, even if you are doing final year MBBS, okay, you should you should uh, your building block will should be like that. So you should be integrating the things. Okay, if you are reading CVS this medicine in the final year, make sure you know the physiology, pharmacology, relevant anatomy and pathophysiology of that system. So this is what you should be knowing, because you are in final year MBBS, but if you don't recall these stuff, your concepts will be bad, and now you will ending up in during your internship and after, sorry, after a house job, and after that when you are preparing for any post graduation exam, whether it is a USMLE or PLAB or FCPS part 1, unfortunately you will suffer. And if you overcome this thing, this will help you in your future. Okay, so thank you very much, all of you, for listening. And I invite and I request all of you to contact me anytime for any guidance or anything, because this is my, like you can say, my passion, and I'm available to help you out whenever, whenever you need, whenever and whatever you need. Actually, the related to specific exams or anything, I have conducted a lot of sessions for career counseling, and there are so many things which I have, and they are available on the YouTube. And by the way, conflict of interest, I have to tell it's not a monetized channel, and I'm not publicizing it for that I will get something out of the world. It's only for making you a better doctor, a better anesthetist. And another important thing is that not everyone is blessed similarly. Like I say that I belonging to a third world country, not a very good training setup, not a very good. If you, Allah has blessed you to get the best of the best, this is your moral responsibility to spread it to others. And another important thing I will tell you, that the best way to learn is to teach. If you want that you don't forget what you learned, please start teaching anyone around you. Start teaching. Okay, so you will not forget. And start asking questions. Don't You should not have any shame to ask any question to anyone. Even if you see some of your junior, your resident knows something, please don't hesitate to ask. Because if you don't ask in macho, and in you have a rod in your neck, unfortunately it will create a big problem for you and your patients. Okay, so no ego. Don't stop the learning door. The day of your life, when you wake up in the morning and you sleep without learning something new, that day of life you wasted. This is my motto, and this is my request. Please spread this message to others. Okay, so thank you very much, and inshallah, actually, over the weekend, maybe we will be discussing pheochromocytoma. One of our colleague, he is ready to prepare that. Dr. Shitivi, if you are the same one who contacted me, I'm not sure whether that person are you or someone actually. Anyways, so thank you very much. Inshallah, we will meet again. And a number of things with reference specifically about any specific exams. A number of things are there, but I am happy to answer your queries anytime. Bye bye. Thank you, Bilal, for your time. Inshallah, see you again. Assalamu alaikum.